Good evening, doctors. I'm Dr. Prachi from Shield Healthcare, and a warm welcome on behalf of Shield. And we are starting our Q&A session with eminent speaker, Dr. Anshuman Mukherjee. I will share my screen. Sir is consultant pulmonologist and interventional bronchoscopist at Fortis Hospital, Kolkata. Sir has a European diploma in adult respiratory medicine from HERME, fellow of American College of Physicians. Sir's areas of interest are asthma, pulmonary hypertension, endobronchial ultrasound, COPD, and pulmonary rehabilitation. Sir is frontline COVID warrior in Kolkata and also avid wildlife photographer. So with this and with Sir's permission, we will begin the Q&A session. So the first question what we have received is in clinical setting, how we are going to differentiate between COPD and asthma.
So I think this is a very pertinent question to start with, and it's really very difficult to differentiate between COPD and asthma clinically, because clinically they behave almost like same, but history is a very, very important factor. When you start taking history, so for asthma, history like atopy, history like suffering from long days, especially since childhood, history like wheezing, cough, history like seasonal exacerbation, these are very, very important. While as COPD, age is an important factor. When the patient is more than 40 years of age, you are going towards COPD rather than asthma. Again, the smoking history is important in COPD also, smoking history, pollution, any other exposure to smoke, dust, etc. The occupational history. So history takes a very important part in differentiating clinically between COPD and asthma. And then comes the spirometry, which will give you a more valuable input about the differentiation between spirometry between asthma and COPD.
Right, sir. Thank you very much. So are there any biomarkers to predict the mortality, especially associated with COPD?
So there are biomarkers. When we are treating a COPD patient or when we are evaluating a COPD patient, biomarkers like CRP is a very important factor, because if there is higher CRP, you know there is infection, there is higher chance of higher the chance of infection, higher the chance of mortality in patient with COPD. So biomarkers like CRP is important in COPD. Other things which I normally prefer is to go for a CT scan, HRCT thorax. This is obviously not a biomarker, but HRCT thorax is an important part. Sequential spirometry is also very important to know about the reduction in FEV1 over the years, or rather over the months, and keeping a track on the patient's exacerbation, how the patients exacerbate or how frequent the patient exacerbate. That is very important when you are treating a COPD patient, because that will guide you about the loss of lung function the patient is having with each and every exacerbation.
Yes, sir. So thank you, sir. So from COPD to tuberculosis, so the question is, what is the most sensitive or specific investigations to diagnose the pediatric tuberculosis?
So I've seen the question. This is a good question, although, but I am not a pediatric pulmonologist, so I must not answer this question. But as far as mine is concerned, I think in case of tuberculosis, you have to, the gold standard or the best diagnostic tool is to establish a microbiological case of tuberculosis. So you have to establish whether the patient is having AFB positive or not, acid fast bacilli positive or not. If you can establish that by any means, you are sure that this patient is having a tuberculosis. Nowadays, there are several other methods like GeneXpert, like line probe assay. So several other methods to diagnose the tuberculosis, both drug resistant and drug sensitive tuberculosis. So they are available, but obviously, if you can establish microbiologically, nothing is more important than. So even in case of pediatric tuberculosis, establishing the case by microbiological method is, I think, the best and the Gold standard.
Gold standard, right, sir. So one question is about the bylastine and its role in allergic bronchitis.
Sorry, please repeat once.
Bylastine role in allergic bronchitis.
So bylastine is a newer drug. Bylastine is a newer anti-allergic drug. Bylastine is good. The main drawback of bylastine, which I felt, is bylastine has to be given twice a daily dosing. But other anti-allergics like fexofenadine, like levocetirizine, desfluraltadine, this has to be given only once daily dosing. So that is the one drawback for bylastine. But overall, bylastine's sensitivity, rather the bylastine's efficacy towards reducing allergic manifestations are quite good. Bylastine can be used in allergic rhinitis. It's a good drug.
Right, so thank you. So next question is, what are the indications where a doctor should approach to a pulmonologist rather than treating they themselves from a physician's point of view?
So this is probably the best question I have received. I saw your list of questions. This is really important. When to contact the pulmonologist? That is very important. So in the era of COVID, most of the people know that, okay, you go to a pulmonologist because the COVID affect the lungs, full stop. But when it comes to non-COVID patients, or if you think about the pre-COVID era, there are aware confusion whether rather we get, in India especially, we get patients who are coming back after showing so many doctors, GP, medicine doctors, cardiologists, even gastroenterologists, so many doctors, and then comes to a pulmonologist to diagnose the case. So I think we need to think about the easy symptoms, the symptomatology for the pulmonology patients. If the patient is having cough, or the patient is having wheezing, a whistling sound in the chest, or the patient could have shortness of breath. Shortness of breath was in 2013 or 14, the patient can walk for 3 kilometers, but right now the patient can hardly walk for 500 meters. The chest tightness, not chest pain, chest tightness, hemoptysis, that is spitting out blood from mouth. So all these symptoms are directly pointing that you should go to a pulmonologist. Also, there are symptoms, associated symptoms like fever, like swelling of the legs. These are associated symptoms which you must not ignore. Obviously, there are so many overlapping symptoms. Okay, there are patients who are coming to us with symptoms of, say, leg swelling. Okay, you cannot be sure clinically whether it is heart failure or whether this is exacerbation of COPD, because exacerbation of COPD or long-standing COPD can also lead to pulmonary hypertension, which ultimately leads to pedal edema. Similarly, if the patient is suffering from congestive cardiac failure, he or she could have this pedal edema. So it is difficult to diagnose, or rather difficult to differentiate clinically whether this is cardiac origin or pulmonary origin. But I told you in the first question that history is a very important part. You take proper history, you will be channelized whether it is a cardiac case or a pulmonological case, and then you go through the battery of diagnostic tool, the normal diagnostic tool like chest X-ray, like ECG, echocardiography, which will give you more insight whether it is pulmonology or a cardiological case. So I think that should be the approach. So you must not be focused from the very beginning. You have to be very much diversified. You have to think about different diseases, and then by history, by clinical examination, and by this basic investigation, you have to channelize to one system which system is affected. That should be the approach in this.
Very right, sir. Thank you very much. Thank you. Sir, again, back to COPD. The question is, if the exacerbation of COPD is not managed by medical management, if it is not responding, then what to do?
So this is important. This is slightly elaborated topic, I guess, and you have to think about how are you managing the case, or how much optimized treatment you are giving to your patient. That is one important fact you need to understand. Now, next thing is, when you are talking about that you cannot manage the patient optimally with medical management, then the question comes, are you giving optimum medical management? Are you providing all the treatments? If no, then provide all the treatment. The question comes whether your diagnosis is right or not, whether it is actually COPD or it is asthma or it is asthma COPD overlap syndrome or some hidden diagnosis could be there. Like got patients in previous years, patient came with wheezing, severe wheezing. Patient was treated for almost 6 months with asthma medication, then with tuberculosis medication, but the wheezing keeps continuing. At the end of the day, when the patient landed to us, we did a CT scan and found that there is a large tumor sitting in the trachea, which is actually causing the wheezing sound. So that can also happen. So you have to be cautious in your approach. You have to think about the diagnostic accuracy, whether you are on a diagnostic accuracy or not. Next, you have to think about whether you are giving the highest medical management or not. And then you have to think whether you are whether the patient is not getting enough relief or not. If you are on highest you are not on highest medical treatment. In that case, you have to think like whether you can start something like LAMA. Suppose in COPD patient, you are giving ICS LAMA combination and the patient is exacerbating continuously. Then you have to give a LAMA, that is long-acting muscarinic agent like tiotropium, like glycopyrronium. There are different newer generation combination like indicator glycopyrronium you can offer the patient. You have to give them a chance of pulmonary rehabilitation, which is very important these days. So breathing exercise, pulmonary rehabilitation, which is very, very important. You have to offer them vaccination also. So vaccination against pneumonia, vaccination against influenza. You have to tell them about lifestyle modifications. So these are things you can optimize. These are things many of the patients are lacking in their routine day-to-day activities. So those things needs to be corrected first. Now, suppose you are giving all these things and still the patient is exacerbating. The next stop for the patient is a hospital. Okay. So in hospital, what to do? You have to categorize the patient, whether you can keep the patient in ward or a step down ICU kind of place, or the patient needs to get into the ICU or not. Okay, so that is another part, that is another area where you have to channelize the patient. Now the treatment is basically between antibiotic, steroid and nebulization. Okay, and you have to find out what is the cause of this exacerbation, whether it is an inflammatory exacerbation or it is altogether an infection. If it is an infection, is it bloodstream or a urinary infection or an infection in the sputum? So that needs to be focused first. And in that plane, you have to run your treatment. That is the whole lot of thing I feel. Another important part you need to evaluate is whether the patient is retaining carbon dioxide when he comes to the emergency, when he landed up to the emergency, whether the patient is retaining carbon dioxide or not. Just do an ABG, arterial blood gas analysis. If you feel that the patient is having a CO2 level of more than PCO2 level of more than 45, then you know the patient is having a type 2 respiratory failure and you have to act accordingly, whether the patient needs BiPAP or ventilator. Another important thing I told you in the first, that it's very hard to differentiate between pulmonary edema, not pulmonary, pedal edema due to cardiac origin and pulmonary origin. So we in our hospital do a simple test called NT-proBNP. NT-proBNP gives us an idea whether the patient is retaining fluid or not. So that is, these are different aspects which you can take care of and you can give a better treatment to the patient.
Right, so it was absolutely elaborative and obviously it will help our doctors, those who are listening to it. Sir, during your answer, you also mentioned about the pulmonary rehabilitation. So can you focus something, can you tell us something more about this?
This is one very much upcoming topic, I guess. Pulmonary rehabilitation, I think in next decade, it will be a very, very hot topic, pulmonary rehabilitation, because even if you give the patient optimum treatment, unless and until you bring back the patient after an exacerbation, you bring back the patient into the normal life, it would be difficult for the patient to come back, and it would be difficult for the patient to gain back the confidence, gain back the pulmonary capacity which he or she has prior to the exacerbation. That is what pulmonary rehabilitation does. Pulmonary rehabilitation actually improves the quality of life. It doesn't reduce the mortality, but it improves the quality of life. So pulmonary rehabilitation in the form of physical exercise, in the form of breathing exercise, you can offer them. So physical exercise, like simple physical exercise, like exercise of the hand, the upper limb muscles, exercise of the legs. These are not going to a gym or anywhere. You can do it at your own place. So rehabilitation means bringing back your muscles to normalcy, muscles of the upper and the lower limb, muscles of the respiratory system. So all the muscles needs to be re-energized, kind of things. Also, you need to take care of the diet. You need to take care of vaccination. You need to take care of the breathing exercise. These are areas you have to focus when you are thinking about pulmonary rehabilitation. The ideal rehabilitation course should be of 12 to 16 weeks, but in our country, it's difficult to provide rehabilitation to all the patients. Generally, what we do is when the patient in hospital and the patient is recovering, the patient can sit out of bed, then we start doing this rehabilitation program. We keep doing this rehabilitation program till discharge, and we give a little kind of thing.
Right, sir. I mean, in between your voice was breaking, so we couldn't hear, but now it's okay. So a lot of COVID-related questions are also getting. So many COVID questions we are receiving. The first question is about the mucormycosis. So diagnosis of mucormycosis and how to manage it.
It's difficult to diagnose actually.
Okay.
When you are, so you have to be very much suspicious actually, very much cautious, very much suspicious whenever you are getting a COVID patient and who is on long-term steroids, who has got diabetes, who has got already immunosuppressed condition, and he or she is on long-term steroid. In that case, you have to think about whether the patient can infect by the fungus or not. It, not only mucor, it could be aspergillus, it could be candida, it could be mucor, each and everything can infect the patient. If it is mucor, why mucor is so much dreaded? Because mucor has a potential of infect the bloodstream. Mucor has a potential of angioinvasive character, that is, it invades the bloodstream, it blocks the bloodstream, it makes clots, which ultimately reduce the blood supply of a certain area. Suppose here the mucor is infecting here, the area is devoid of blood supply in a very quick time, which ultimately lead to necrosis. So that is the bad part of mucor, and in that case, you have to diagnose it as early as possible. Clinical suspicion has to be very high. If you see any black area when you are treating the patient for a long period, you are giving steroid to the patient, and the patient is having a black area at any spot of time. It could be a upper part mucormycosis, it could be a pulmonary mucormycosis, it could be an abdominal mucormycosis, or a generalized one. So you have to be very cautious. You have to check the patient all the time, every day, clinically, whether there is any sort of black spot or not. If there is a black spot, the first and foremost thing is to do a tissue biopsy as soon as possible and send it for culture. Ask your microbiologist to give early report whether there is any fungus or not, whether there is any mucor or not. If there is mucor, the treatment has to be by amphotericin B or posaconazole, or there are several newer kind of antifungal drugs. But another important part is to get the area taken. The area has to be taken out from the surface of the tissue. But like mutilating surgery performed by the ENT persons are quite common in mucormycosis cases.
Right, sir. Right. Thank you very much. So I hope you are not tired. Okay. So the next question is about when to start a systemic corticosteroid treatment, and especially in COVID-19 patient, and will it be prevent the immunopathology which is seen in severe cases?
Actually, starting starting a intravenous steroid is a very crucial part of COVID treatment, because if you start it early, you might invite more and more viremia. You might reduce your body immunity more, and you might invite viremia. But if you start late, it could actually the inflammation could destruct your lung, destroy your different immunological system. So the timing is very crucial. What I do, or rather, what is the general protocol to do to go for invasive? Not invasive. To go for intravenous steroid is number one. If the patient is having desaturation, so saturation less than 94% at rest, or if the patient, whenever the patient is walking, the saturation is going below 94%. So that is one case. Rapid desaturation is very, very important. Important criteria to start steroid. Number three is continuous fever which is not subsided, even with paracetamol, higher dose of paracetamol, even after 6 days. That is important. So these sudden onset respiratory rate, high respiratory rate, that is tachypnea, more than 30 respiratory rate, which is another important cause. If there is any exacerbation of obstructive airway disease, which we often see in patients with COVID, so there is a viremia ongoing and the patient is having obstructive airway disease, patient is wheezing, patient is having breathlessness, chest tightness, in that case you can start intravenous steroid. So these are the criteria where you can start intravenous steroid and you can give relief to the patient. Also, a very important part is ARDS, acute respiratory distress syndrome, where you have to be very cautious and very, very quick to start this intravenous steroid, because unless and until you give steroid, the inflammation will just destroy the whole lung, which we saw actually in the second wave in so much amount, in a huge amount of patients.
Right. So next question is obviously the COVID-related ARDS only, and the management of the ARDS associated with COVID. So that's the next question, sir.
So when we are treating ARDS, first you have to categorize ARDS, whether it is mild, moderate, or severe. If it is moderate to severe ARDS, you have to be quick, you have to be cautious, give steroid as per the body weight. Don't be afraid to increase the steroid dose to prevent the ventilation perfusion mismatch. The important part is lung protective ventilation. If the patient is on ventilation, lung protective ventilation is very important. That is as per the body weight. But in ARDS, you have to increase the PEEP, that is the positive end expiratory pressure in ventilator settings. Also, you think about prone ventilation. You keep the patient prone, upside down. So the patient will lie on his chest and abdomen, and you keep the patient for 16 to 18 hours. Okay, supine the patient again, see about the desaturation, how much desaturated, how much requirement of oxygen goes up, and how quickly it happens. That will guide you whether you can turn the patient upside down for how many times. So the recommendation is 3 to 5 times, not more than that, but I think 3 times, thrice. If you do thrice proning, that would be enough. If the patient doesn't improve or doesn't respond after 3 times or maybe 4 times of proning, this is going to be a tough challenge. So that is the main part of treatment for ARDS, which we have to do. Also, you have to give ample antibiotic coverage because you are giving higher dose of steroid. In case of COVID-19, you know about the syndrome called cytokine storm. In cytokine storm, if there is desaturation and if there is cytokine storm, if there is higher level of IL-6, you have to think of that whether you will give tocilizumab or not. So that is another thing, tocilizumab, which can prevent, not fully, but which can prevent this ARDS kind of things. Dr. Prachi, you are muted.
Next question is about that only, about tocilizumab, the rationale, especially in the ICU setting. So when to start and what is the rationale?
So just look out for two things. If the patient is having infection, so look for CRP and procalcitonin. If the CRP and the procalcitonin is in normal level, so you know the patient is having inflammatory surge, inflammatory challenge. And if the patient is having rapid desaturation, these are two criteria. If they match, you can go for tocilizumab. So tocilizumab 400 and second thing is the patient is having rapid desaturation. That's it.
And sir, initially, a lot of protocols did mention, I mean, the state level protocols, COVID management did mention about the ivermectin, especially in Maharashtra. So what is your opinion about ivermectin in COVID-19?
So that's a good question. There are several drugs like ivermectin, like loperamide, lopimmune, that is, I think, lopinavir and ritonavir combination, initialed as HCQS. So all these drugs are proven to be inefficient in reducing COVID-19. There are some evidence with ivermectin that ivermectin reduces the viremia. So ivermectin reduces the hospital admission or hospital, the duration of hospital stay. But I think at the end of the day, it's a viral disease, and there are very few drugs other than remdesivir. I felt there are not so important role of these drugs because they don't actually help in quick recovery of the patient. That is my take. That is my opinion personally. Yes, I have given ivermectin in so many patients, but at the end of this COVID-19 second wave, I felt that not even ivermectin is a good drug to reduce the virus. So mild to moderate disease you can give, but it's not a big drug. Not a kind of Pandora's box that will give you full opportunity to treat the patient.
Thank you, sir. So you had mentioned there is an end of second wave. So is there a third wave possibility, and what's the opinion?
I hope there is no third wave because we are tired.
Yes.
So what I felt is the second wave is still not over. You know, we are getting almost near about 40,000 cases per day till date. 40,000 cases per day and a death rate of nearly 500 to 600 per day, which is quite worrisome. Now, just for a statistic purpose, you know, when we are in the starting of first wave, the daily caseload was 0. In the starting of second wave, the daily caseload was around 12,000 per day. Right now, it is 40,000 per day. If the third wave starts, that will create a havoc. Given the fact they are having they will prepare almost 20, at once it has been almost 25% of patients. So if we add these two factors, that will give us an idea that almost 40% of the patient, 40% of the total population are being infected or being vaccinated. Okay, so there is a chance that the third wave will be slightly lower than the second wave. But given the fact that the caseload is still 40,000 per day, this is my fear that if the third wave starts happening right now, it will create havoc in this country.
Okay, sir. Fine. So again, back to asthma. Are these patients more prone for COVID-19 infection? Patients with asthma.
So any patient with lung disease are more prone to COVID-19 infection. Full stop. So it's not about asthma, not about COPD, not about lung cancer. Any patient with any comorbid condition, especially any comorbid condition from the lungs or comorbid condition like diabetes and hypertension, are far more prone to COVID-19 and far more prone to develop moderate to severe. That's it.
Sir, any opinion about the intranasal corticosteroids for the COVID-19?
Intranasal
Corticosteroids.
So intranasal corticosteroid is quite common when we are treating allergic rhinitis, but so I don't think intranasal corticosteroid, I don't have the data or I don't have the clue whether intranasal corticosteroid is important or not. When we are using inhalational corticosteroid in the form of budesonide in a slightly higher dose, that is 800 milligram twice a day, it obviously reduces the inflammation in the upper airway, and it actually helps in mild to moderate variety of patients to reduce the symptomatology. So that is important actually, but I don't know, I don't have a clue about intranasal steroid.
Right, sir. Thank you. So back to pneumothorax. The question is surgery essential in case of a pneumothorax, basically the punctured lung, or can it be managed by medications?
No. So, so I don't know who has questioned it. I don't know what he wants to mention about the surgery, because there are certain criteria. There are some book teaching criteria about the pneumothorax management. And if the pneumothorax is out of that criteria, you have to give a drain. You have to put a drain. If it is a secondary pneumothorax, that is a pneumothorax on a diseased lung, you must have to put a drain. So I don't consider putting a drain as a surgery because it's a minimal invasive surgery. But if there is prolonged bronchopleural pneumonia, in that thoracoscopic surgery to clip the area, that's a definite surgical process. But that is a minuscule variety of patients who require those kind of procedures. Otherwise, putting a drain or normally putting oxygen can give you quite important benefits.
Right, sir. Thank you, sir. One more question again related to COVID. Is there any pathophysiology, or does the immunothrombosis contribute to the pathophysiology of COVID-19? So,
because of this COVID-19 virus, there are different immunological phenomena. The one phenomenon I told you about, the cytokine storm. And this cytokine storm leads to inflammation, which ultimately leads to hypercoagulability of the blood. So this hypercoagulability of the blood can lead to thrombotic events, especially thrombosis in the pulmonary veins, pulmonary arteries, also thrombosis in the deep vein of the legs. That can happen due to the hypercoagulable state because of this hyperinflammatory disease. That is the pathophysiology of COVID-19, rather the thrombosis of COVID-19.
And so immunosuppressive agents for improving pulmonary pressure, role of immunosuppressive agents. So can I repeat? Role of immunosuppressive agents for improving pulmonary pressure.
Improving pulmonary pressure.
Yeah, I guess doesn't make sense.
Doesn't make sense, because if there is increased pulmonary pressure, we always try to reduce it. Why should I increase the pulmonary pressure? No, I don't have a clue. I don't think it makes sense.
Yes, maybe some typo error, sir. I will check again. So the next question is, if the patients, COVID patients are home-based, then what are the parameters which indicate that they should be getting hospitalized?
This is a very important question. What I mentioned in the criteria for intravascular steroid, that is actually important over here also. So you have to think about fever. If the fever is continuing, if the patient is having desaturation even at rest, if the saturation is going below 94%, if the patient is having a respiratory rate of more than 30, or if the patient is showing any sort of distress, needs to be hospitalized in an urgent basis.
Sir, lymphopenia is noticed in COVID-19. So is it any predictor of the severity? Can we consider lymphopenia as when we are managing the COVID-19 patient as far as severity is concerned?
So lymphopenia is a common thing in any viral disease, but COVID-19 is causing lymphopenia in a huge scale actually. So there is the lymphopenia itself is not a marker, but the NLR ratio, that is a neutrophil versus lymphocyte ratio. If it is more than 3.5, so the neutrophil is more and the lymphocyte is minuscule. So that is important. If it is more than 3.5, you have to think of a grave infection, which might lead to cytokine storm and things.
So most of the questions are covered. The last question is about, I know, sir, it's about children actually. They are not getting infected. A lot of cases are not there. So any reason behind that, and what's their role in COVID-19 transmission? So that's the question we have visited.
So there are a few controversial topics. There are a few controversial studies, not studies, facts that few told that children are not being infected in so high
severe.
Next is because they are still not vaccinated. No children below age of 18 are still not vaccinated. That could be a reason that the children are slightly more prone towards this disease right now. But I think children are mostly asymptomatic carriers. The manifestation of the disease is slightly lower in children below 18 years of age. That is my take. I told you I am not a pediatric pulmonologist, but that is what I feel.
Okay. So question is there about pregnant women and vaccination, but I will skip this question. So
as per the new government guideline, I think pregnant and lactating women can take the vaccine.
Allowed, yes, sir. They are allowed and they can take it. Yeah. So one more question is how to manage your post-COVID pulmonary embolism.
So very good question, I guess. So post-COVID pulmonary embolism, you have to diagnose it first. So what is the criteria of diagnosis? If you see the patient is having disproportionate dyspnea, so the patient is breathless, but you cannot match it with the clinical scenario. If you if you do a 6-minute walk test, there will be sudden or there is rapid desaturation of the oxygen level. And if you see the D dimer is still very high, straightway go for a CT pulmonary angiogram if you have the availability. If you don't have the availability, no issues, straightway go for the anticoagulation. What anticoagulation? I prefer if it is normal creatinine, normal LFT, I prefer to start with the newer anticoagulating agent like rivaroxaban, like dabigatran, like apixaban. If there is complication, if you feel there is the creatinine is the issue or the LFT is an issue, straight away go for heparin. So start with heparin and then as per the choice, change it to acetrom or anything else, or rather warfarin or something else. So that could be a possibility. So this is an important question, a very, very upcoming topic about this pulmonary embolism.
So that was the last question actually. So apart from that, if you want to add a few points from your ends, that would be very helpful and crucial.
I think I have covered the whole pulmonology book.
Yes.
I need not to add anything. So
Okay.
these are very, very important question and very good question these days. So
Thank you, sir. Yes. Thank you for your time. And I guess you just came from the hospital and directly came to this webinar. So thank you very much. So we have a short video of our drug. So if you allow us, we'll play for a minute or so. Right?
Sure.
Thank you, sir.
Please.
Nishant, over to you.
Yes, yes, ma'am.
Dr. Shield Healthcare, transforming health with innovation and technology, is the winner of the prestigious Indian Health and Wellness Award. Likes to thank you for helping us achieve through your valuable partnership. Health issues like recurrent respiratory infections can cause complex physiological and biochemical changes leading to ambulatory condition. Therefore, we need a specific immune booster to strengthen the respiratory immunity. So, introducing Rudimin Mu tablets and Rudimin Mu syrup to strengthen the respiratory immunity. Rudimin Mu tablets and syrup are a specific combination of 4 bioactive ingredients along with immunovitamins and minerals. The bioactive ingredients are tinocoridin, curcuminoids, Asimenin, Osimum sanctum. Rudimin Mu is also enriched with immunovitamins like vitamin A, vitamin C, vitamin D3 and minerals like zinc and selenium. As per ESPN guidelines May 20, daily allowance of vitamins, minerals and trace elements maximizes nutritional defense for patients susceptible to frequent respiratory infections. Therefore, please prescribe Rudimin Mu tablets and syrup in recurrent respiratory infections. Only Rudimin Mu strengthens the respiratory immunity. Dose of Rudimin Mu tablet is 1 tablet BID. Dose of Rudimin Mu syrup is 5 ml BID. Doctor, Rudimin Mu shields immunity. Thank you.
So thank you, Nishant. Thank you, sir. Thank you very much for your time and all your support. We are really grateful. And thank you very much from the Shield family, sir. Thank you.
Thank you and good night.
Good night, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Bye-bye.
Thank you. Bye, sir.
Bye.